So if you could please check into the session. You need that for the feedback and also for the...
Someone was concerned yesterday it was going to post somewhere on social media or something. It's literally distracting, so don't be worried, even if you're not proud of being here, which would be odd.
So we kind of got already introduced, so we don't need to do that anymore. So we get started. You know about the cactus. That we see the cactus too, so if you don't respond to the cactus, then before Dr. Powell comes up, I will probably nudge you a little bit, so he doesn't have to get up here. But really, we want to keep on time because it is busy. So we're a little ahead of the schedule, but we're still going to keep to the time limits. So our first presentation is going to be by Dr. Sarah Mansfield, who is already here. And she's going to talk to us about enhanced recovery after surgery for pediatric abdominal tumor resections, shortens hospitalization, and decreases opioid use, a prospective multi-institutional study. Good morning.
Thank you so much. I'm Sarah Mansfield. It's an honor to be presenting for all of our study authors who have nothing to disclose. Enhanced recovery after surgery, or ERAS, is an evidence-based standardized approach to improve recovery perioperatively. It has become standard of care in several adult operations where it has been demonstrated to decrease complications, shorten length of stay, decrease opioid use, and improve nutrition and patient satisfaction. It is increasingly being used in pediatric populations but has not been rigorously studied in oncology patients. It is particularly important in these patients as they often require intensive multimodal therapies. Due to these therapies or the tumor itself, patients often experience nutrition alterations, deconditioning, and significant opioid exposures. Exacerbating any of these perioperatively can lead to delays in adjuvant cancer-directed therapies. So this was a multi-center prospective study with propensity-matched historic controls with a goal of decreasing 90-day complication rates. We included all patients older than 1 month of age undergoing abdominal tumor resection between 2020 and 22. Our matching variables and our statistical approaches are listed here. A protocol was developed utilizing accepted ERAS principles with modifications from our study team. The protocol outlines 20 process measures with specific definitions. A few of the highlights include counseling to set expectations and a clear carbohydrate load the morning of surgery. Regional analgesia was tailored to the case and encouraged to be on and working during the case. Euvolemia, normothermia, and opioid reduction goals were all explicitly stated. An MIS approach was encouraged when oncologically feasible. NG tubes were avoided, and feeding was advanced at a minimum of clears on post-op day 0 and regular on day 1. Multimodal pain regimens were ordered from the OR, and our opioid goals were also explicitly stated. Implementation was tailored at each of the site and included key stakeholders. During dissemination, it was emphasized that the process measures were goals and were not to override clinical judgment. It was unlikely that patients would achieve 100% of the targets, but that did not disqualify them from the study. We enrolled 95 patients into our prospective ERAS cohort, and these were compared to 95 historic patients that were well matched for all of our variables with age, gender, weight, race, prior therapies, and diagnosis shown here. This was our scorecard with our historical percentages included for reference. We reviewed similar scorecards at our regular audits. A few things to point out. We were able to achieve the clear carbohydrate load the morning of surgery in 77% of patients. During early audits, we appreciated how poorly we were obtaining our normothermia goals. Therefore, each of the sites made targeted interventions, and we were able to increase this throughout the course of the study. Regional analgesia usage was high in both cohorts, but despite that being similar, patients in the ERAS cohort were actually more likely to reach their lower opioid targets. MIS approach was driven by the oncologic feasibility and performed at similar rates to historic patients. Twice as many patients left the OR without an NG tube, and our post-op opioid goals were achieved in 74% of our patients. When we look at how the protocol impacted specific data points, the median operating room time was not different between the two groups, with similar regional analgesia rates. Intraoperative crystalloid volume decreased from 14 cc's per kg per hour to 5. Patients received their clear liquid diets and regular diets 2 days sooner in the ERAS cohort. Opioid, the IV fluids and mobilization occurred 2 days sooner in our ERAS cohort. And our opioid consumption dramatically decreased from 0.23 to 0.08 in the setting of higher adjunctive pain medicine utilization. Despite our decreased opioid consumption in the prospective cohort, pain scores were not negatively impacted and were actually better in ERAS patients on days 2 and 3. There was a trend towards shorter length of stay and shorter time to clearance for chemotherapy, and no difference in our reoperations, ED visits, or readmissions. So for our main outcome, there was a significant reduction in complications as these were reduced in half in our ERAS cohort. Importantly, this reduction was seen across grades 1, 2, and 3, so some of our more severe complications. Also of note, even though we advanced diets sooner, the NG tube reinsertion rate was not different between the two cohorts. In conclusion, pediatric surgical oncology patients, ERAS is feasible, decreases complications, decreases opioid consumption without worsening pain scores, promotes earlier mobilization, and proves diets may be advanced sooner without negative effects. There are limitations in utilizing a historic control for comparison, and it should be noted that ERAS had already permeated many of our centers prior to the start of the study. Moving forward, we have several deeper analysis planned, including differences in compliance. We have patient surveys to evaluate, and a deeper look at our adjunctive pain meds. Additionally, operations are heterogeneous, and fine-tuning this protocol to organ-specific procedures may further improve outcomes. So we'd like to thank the many people involved at each of the centers. There are too many to list here, and I'd be happy to take any questions.
Paper is open for discussion. Dr. Heiss.
Just a quick question. Magnificent presentation. Could you talk just a little bit about how important the audit meeting is in the enhanced recovery system? This is really built on quality improvement principles, and many of the papers skip discussions about audits. And then secondly, could you just enhance that by explaining one treatment failure that you guys found in your audit meetings that significantly made an impact in improving your protocol?
Yeah, absolutely. This is basically a quality improvement project, and our audits functioned as PDSA cycles. So as I mentioned, we did not appreciate our normothermia problem. So that was one of our early, acknowledgments during our audit meetings. Each of the centers have different resources available to them. So what works at our center may not work at the other centers. So each place had to figure out their own improvements. Quality improvement is specific to the institution, and work to improve those. And those audits really helped us stay on track and make sure that we were going the right direction.
We have a question from the chat. Dr. Ochoa?
Question from Dr. Calkins. Why so many NG tubes still?
So we did reduce them quite a bit. This is a practice change. Historically, these patients were managed how your preceptor managed them and how their preceptor management, them, and basically any abdominal surgery got an NG tube in the previous generation. So this was hard for some people to accept. We don't have a lot of GI resections in these patients, so we felt pretty strongly that we were safe in not leaving them. But for bilateral Wilms or extensive neuroblastomas where you're mobilizing the intestines both directions, some people still felt a little uncomfortable removing them at the end of the surgery. But I hope that our data will make people feel a little bit more comfortable with that.
Thank you.
Thank you.
Next up, we have Dr. Sarah Pfeiffer presenting a decade in review, characteristics and outcomes of fetoscopic endoluminal tracheal occlusion for congenital diaphragmatic hernia at a large fetal center.
No injuries.
Sorry. It's a bit of a hike from the back of the room. Thank you for the opportunity to present our work. My name is Sarah Pfeiffer. As the Clinical Research Fellow at Texas Children's Hospital, I have a strong interest in health services research and clinical outcomes in congenital anomalies, including congenital diaphragmatic hernia. Today, it's my pleasure to share with you our institutional data regarding the experiences and outcomes that we've had treating severe CDH with FIDO as we all work together to improve outcomes in these high-risk patients. I have nothing to disclose. As we all know, congenital diaphragmatic hernia is a major congenital anomaly with significant associated morbidity and mortality. This morbidity and mortality is primarily attributed to pulmonary hyperplasia, which results in pulmonary hypertension and significant respiratory distress in the newborn. Occlusion of the fetal trachea has proven to be a significant treatment mechanism for these sick babies. Occlusion of the trachea increases the tracheal and lung pressures, leading to cellular and molecular changes, which leads to increased functional lung volume upon delivery. This has been associated with increased fetal survival, decreased need for ECMO, and improvement in pulmonary hypertension among these high-risk patients. The total trial has demonstrated that FIDO is a feasible treatment mechanism for these patients. However, there are still wide varieties in the practice mechanisms across the US. Many institutions are using FIDO under clinical trials, but it's still not the standard of care. There are some limitations to the use of FIDO, including the high resource requirements for both institutions and families, as well as the associated risk factors, including premature preterm rupture of membranes and tracheomegaly. In this study, we seek to share our institutional data in order to help us all work together to figure out the best mechanism to treat these high-risk patients. So in this study, we'll describe the characteristics and outcomes of the patients who have undergone FIDO at our institution over a 10-year period. We retrospectively reviewed all 213 CDH patients at our institution, of whom 41 patients underwent FIDO. There were 14 patients that were excluded from our final analysis, 12 of whom did not meet the protocol criteria, primarily because of a discrepancy in the balloon use early in the study. One patient was excluded from the final analysis because they failed FIDO placement, and one experienced intrauterine fetal demise and therefore was excluded from our final outcomes characteristics, leaving 27 patients for our analysis. Our primary outcome was survival to discharge, and we had 85% survival. And in this study, we'll compare the characteristics and outcomes of our survivors to our non-survivors. Our cohort was predominantly male, Caucasian. Nearly 40% were out-of-state referrals, and the median distance traveled to seek care was 253 miles. The median gestational age at diagnosis was approximately 23 weeks, with an initial observed to expected total fetal lung volume on presentation of approximately 21%. And most of them were on the left side of the chest. We did note that there was a significant improvement, or the patients who were survivors had significantly better observed to expected total fetal lung volume compared to non-survivors, but there was no statistically significant difference in the liver herniation rates or the lung-to-head ratios. The median gestational age at FIDO insertion in our cohort was approximately 29 weeks, with a median duration of 38 days. All patients in this cohort were inborn at our institution at a median of 36 weeks gestational age and a median birth weight of approximately 2,600 kilograms, or grams, sorry. There was one patient who died on day of life 1, but the remaining 26 patients underwent CDH repair at approximately 4 days of life. About 1/3 of our patients underwent ECMO, and more than half of them had type D defects. The median length of stay for our overall cohort was 77 days, but was significantly higher among our survivors compared to our non-survivors. The median day of life for death for our non-survivors was approximately 3 weeks, about 20 days. We had an 11% 30-day mortality and a 15% overall mortality. Most of our patients did get intubated on day of life 1. In fact, I believe all of them did, with a median duration of intubation of approximately 28 days. About 50% of them went on to be discharged on oxygen. About 20%, or 1 in 5, required a tracheostomy. Nearly 40% required a G-tube, and approximately 1 in 5 had a recurrence requiring a repair. There are several limitations to our study, including its retrospective nature, relatively small sample size, albeit somewhat large for a fetal retrospective series, and the fact that it's a single institution study. In conclusion, we had remarkable survival rates, with 85% of our patients surviving to discharge. We were able to save babies with observed to expected total fetal lung volume as low as 14%. And we were able to save 8 out of 11 patients with observed to expected total fetal lung volume less than or equal to 20%, which suggests that fetal remains a feasible treatment modality for these high-risk patients. I'd also like to point out that these patients do remain medically complex, and survival to discharge isn't the only important outcome. We did note that approximately 1 in 5 patients still required tracheostomy and had significant respiratory distress as they age. So fetal isn't the only answer. We need to continue to work to improve the lung outcomes for these children. I would like to thank all of my mentors at Texas Children's Hospital, and I'm happy to take any questions.
Question from the back?
Hi. The balloon that's used for fetal is called the gold balloon. Now that it's not readily available because the company that's making it, I think, is stopped making it, what are the plans in the future for the new replacement?
That is an excellent question, which unfortunately I am not currently aware of the answer to, but I can definitely find that information and try to get back to you. I'm sorry, I'm not quite sure.
I can answer that question.
Thank you.
Sorry. So within NAFNAT, we are working with the company, and they are currently still making it and providing it for those of us that are in the fetal consortium.
Thank you, Dr. Perrone.
Paul Losty, Liverpool, UK, Bangkok, Thailand. Could you tell us a little bit about the 26% recurrence rate? Because these families have gone through quite a journey. And that concerns me a little bit, that you have a 26% recurrence rate for this population. When did the recurrences occur, and how did you first repair the diaphragms? What way did you do it?
I believe all of our patients had initially undergone a CDH repair with a patch, especially because they're all such large defects. The range of the recurrence rates was between 3 months and 24 months, with a median of about 5.5 months for the patients who had recurrences. I know there was at least one patient where his defect was so large that the patch had to be affixed to the ribs, and he required multiple revisions because we had to keep on.
Yeah, I get
yes.
that, but did you do MAS repairs in these patients, these high-risk patients? Because we know it's a 3 times greater recurrence rate than the classical repair. I'm just trying to get my head around how you repaired the defects in the first place for such a high recurrence rate.
Thank you for the question. I would have to double check to see exactly which type of repair. I can get back to you on that. Thank you.
Diana Farmer, California. First of all, I just want to congratulate you on this work and thank you for presenting it here. A couple of questions. First of which is, who does the procedures at your institution? And is it a requirement of getting the procedures? Because I'm guessing not all 100 of these people are Texans, although it could be. Texas is getting bigger all the time. That they have to stay at your site in order to be delivered there, and if so, do you provide any assistance for folks that are from out of state, et cetera? And then my final question is maybe more of a comment. I do think with 100 patients now, it is important in time to try to bring a little more rigor to this work in terms of comparing it to either a very strong and rigorously evaluated cohort or another, ideally, of course, a randomized trial. But this is they're relatively late gestational age when treated. the addition of a tracheostomy in a high percentage of patients on top of being a CDH, I think is fairly significant. And I think it's really hard to evaluate these data in terms of the current relatively good success rate, even with high-risk CDH patients today. So I think without having a good comparator arm, it's difficult to interpret the true value of this procedure. And we need to know, it's really important. It's fairly easy to do, so it could be something that, you know, solving all the problems that you are working on, NAFNet is working on. So, thank you.
Thank you for the excellent questions. I've been informed we're running out of time, but I do agree, yes, we do need to make sure that we're looking rigorously and making sure that we have great comparison groups. So I appreciate that. It's well taken. As far as who treats the patients, we work closely with our MFM colleagues to perform the fetal insertion and fetal balloon removal. And then we do have quite a few patients who are from out of state. We require all patients, whether they're Texans or non-Texans, to relocate to Houston for the duration of the fetal procedure. And we do provide resources to help support them during that transition, because it's quite a burden on a family to have to relocate for potentially more than 6 weeks or so. So thank you.
One more question?
No,
In the
we are out
interest of time,
sorry.
we're being told we have to move on.
Our next presentation is by Dr. Paolo De Coppi, who almost everybody in the room probably knows. He will talk to us about the assessment of functional muscle regeneration of transplanted tissue, engineered esophagus in the mini pig model. Thank you, sir.
Dear Chairman, dear colleagues, it's a great pleasure to share with you some of the data about the esophageal tissue engineering. I'm presenting on behalf of Natalie Durkin that couldn't come to the conference, unfortunately. Some of the technology I'm discussing today are included in this patent application. So our group has been interested in tissue engineering for a number of years now. We, in 2010, transplanted the first engineered trachea using a decellularized trachea seeded with autologous cells. But if we want to move on to other organs, things become a bit more difficult. And we've been working for approximately 10 years to try to engineer esophagus, and we show in a small animal model that this is possible to engineer a functional esophagus, and we published this a few years ago. But now we want really to go translational, so we wanted to try that in a large animal model with the scope to use these for long gap esophageal atresia. This is a complex slide just to show the process of doing an autologous transplant in a mini pig. So we took biopsy from the rectus abdominis. We did that to mimic what will happen in patients. So to take this biopsy, have the possibility of isolating fibroblast and mesangioblasts. Mesangioblasts are muscle cells. They are bipotent. They can be differentiated in skeletal muscle and smooth muscle, and you understand immediately why we use those cells. So we expand those cells, and we seed it on the decellularized esophagus, as you see there. We sort of nurture the esophagus in a bioreactor, and then we transplant it autologously, orthotopically in the thorax using a 2.5 centimeter defect. This is to avoid to have a vascular graft and to help with the vascularization. We cannot overcome that limit, as described many years ago by our fellow Judah Folkman. So the clinical plan was designed together with the license holders, and we took the biopsy 2 months before the implantation. So this was the graft production time. And then we implanted in pigs and followed them after 6 months with regular endoscopy and checks. So I want to emphasize mainly the problem that we had, that we become familiar to any esophageal surgeons here, that are foreign body obstructions, hyperplastic epithelial polyp formation in some of the animals, stand migration and stricture. All problems that are solvable in a clinical setting and also in an animal setting, but we had some humanized sacrifice of the pigs because we overcome the number of endoscopy that were allowed by the license. Despite that, we observe a normal growth of the animal during the study period. And most importantly, we did some analysis of those esophagus before sacrifice with endoscopy-guided high-resolution impedance manometry done blindly by the gastroenterology, showing essentially that we had a confirmation of secondary peristalsis in the pig that were examined after air and saline boluses. We could also observe that once those esophagus were taken into the lab and we did isometric contractility testing, we observed that we're sort of confirming the data of the manometry, showing a good contractility of the muscle complex. This was not a surprise since we observed a neuromuscular maturation during the time, and so at 6 months resembles some of the native feature of the muscle in examination. And here you see more representative of the old histology. The epithelium was never a problem, even if was not seeded, was covered, the esophageal was covered within a few weeks after implantation. And you see in the graph the reorganization of the muscle that resembled different layers that are observed in the native esophagus. So in conclusions, I present to you today that autologous tissue engineering graft for replacement of esophageal defects are safe in this porcine model, that are reproducible with a clinical relevant timelines, and morbidity is what we do expect in long gap esophageal atresia. They are treatable endoscopically, and the graft become functional and integrated at 6 months. And thank you to all people that work on this project. You see there in the slides, this is the pile of cells that is needed for one pig, for one esophagus, just to give you a scale of what is needed for those tissue engineering complex. Thank you very much. I'm happy to take any questions.
Paper is open for discussion.
James Dunn, Stanford. Can you tell us the muscles that have formed, did they come from your seeded cells versus ingrowth from the edges? And also, can you comment also on the presence of neural elements within your construct?
Yeah, those are two very good questions. These experiments were designed for the MHRA, so the FDA, the UK FDA. And so after discussion with them, we couldn't label the cells. And therefore, we cannot answer completely that question. But we have some element on single-cell analysis that is still preliminary, so that's we didn't present here, that showed that some of the cells up to 3 months were present after seeding. But after 3 months, we couldn't find any of the cells that we seeded on the muscle. So somehow are very important to promote the initial regeneration, but then they are sort of replaced by the body. And this is just what Chris Brewer and others has presented before on the vascular, for example, that after a few months, these cells disappear. Regarding the neuromuscular element, they certainly migrate from the close proximity. This is a 2.5 centimeters, so it's not so long. So they do migrate from the esophageal muscle. Thank you.
Quick question. What do you think is your first patient going to look like that you're going to try to use that on?
That's a very good question. And we are trying with our associate to understand which one will be the first patient. But in order to provide a good vascular bed, I think will be a pure long gap esophageal atresia with no previous surgery. For two elements. First, because we always have a plan B if that fails. And second is because if we have a scar tissue, that would be very difficult for this esophagus to be implanted. However, what we have discussed with the regulator is that we will have the graft ready, but if we can't put the esophagus together, we will trash the graft, of course. If we cannot put it together, then we will use the graft. That will be our ethical process to give the best chance to the graft to work, but also to the patient. Thank you.
Thank you.
Dr. Wong?
Casper Wong from Toronto. Paolo, amazing work. Great to see how you have developed and progressed this particular project through the years, and it's very gratifying to see you achieving success with this. My questions are twofold. One is, does it matter the scaffolding and how long the scaffolding lasts? Because as you described, all the cellular tissue that grew into it actually ultimately goes away and gets replaced by other tissue. So if the scaffolding disappears too early or too late, does that matter, number one? And then number two, what is the longest gap that you've been able, what's the longest tube that you've been able to grow in vitro?
Well,
thank you for your presentation.
Thank you, Casper. Thank you for your kind words. Two very interesting questions. The first is we are using distro-rise tissue because we have years of experience with other tissue as well, and we have seen that gives the possibility to remodel and to grow with the patient, which is very important for pediatrics. So we haven't never gone close to any polymer just to disclose what has happened in other center, for example, with the trachea. So we know that this growth with the patient. So our first trachea patient that is an adult now is doing really well, has had one operation. That operation in 2010 is now an adult, and we know that the graft has been growing with the growth spare of the patient. In order to achieve a free flap, if you want, without a vascular connection, we have seen that more than 4 centimeter would be very difficult. And I think as an alternative scaffold, there are various alternatives, but you need something that gets remodeled with the patient. That's very important. Thank you.
Going to move on to the next.
Thank you so much.
Thank you.
Next up, we have Dr. Stephen Hartman from Cincinnati Children's presenting multi-institutional prospective study demonstrates frequent utilization of GIPS trephination with high healing rates among pediatric patients with pilonidal disease. Dr. Hartman?
Thank you for the opportunity to present our work. We have no disclosures. Pilonidal disease is a pervasive and recurrent condition associated with painful abscesses along the natal cleft. Prior study has largely been limited to single center and retrospective evaluation. Additionally, there have been prior concerns about the safety and tolerability of the GIPS trephination procedure. Our purpose of the study was to hopefully provide a more comprehensive understanding of the treatment options and outcomes available from a large cohort. There are multiple treatment options for pilonidal disease, including both non-operative or medical, as well as surgical management options, the surgical of which have a wide range of associated morbidity. Unfortunately, pilonidal disease is associated with recurrence, and therefore there is no consensus on the optimal treatment strategy. We conducted a multi-institutional observational cohort study among 10 pediatric hospitals as part of the Midwest Pediatric Surgical Consortium over a 4-year period. We enrolled children and adolescents with symptomatic pilonidal disease. They were selected for primary surgical or medical management, and we followed them for symptoms and complications, including a combination of clinical chart review, as well as 3 separate time points of patient survey data. Our primary outcome were the proportion of patients who reported healing at 1 year, according to different management techniques, with secondary outcomes related to time to healing, complications, as well as quality of life metrics. 249 patients were enrolled in the study with a mean age of 16.6 years. Just over half of the patients were male. A majority of patients identified as white, with almost 10% of patients identifying as Hispanic. The mean BMI for our patients was 29, and as you can see, a majority of our patients were either overweight or obese at time of enrollment. For just over half of the patients, they presented with sinus-only disease, and what's important to note here is that 2/3 of the patients presented with their first initial episode of pilonidal disease, with an additional third presenting with recurrence. Many patients had some other intervention prior to their enrollment. As you can see, about 75 patients underwent incision and drainage, with a large group, almost double that of the IND group, undergoing antibiotics. As you can see in our consort diagram, 153 patients of the 249 were selected for surgical management, and 96 underwent medical management. During the course of the study, 23 of the 96 patients converted to surgical management of their disease. As you can see, 133 patients underwent a GIPS procedure. We evaluated patients according to their proportion of healing at 12 months by whether or not the patient had surgery. And what we saw is that 84% of the patients in the surgery group reported healing at 12 months compared to 74% in the medical group, which was approaching significance. We next wanted to evaluate if recurrence played a role in the healing outcomes. When we separate the patients according to whether or not they had recurrent disease at time of enrollment, what we identified is that patients that presented with their first episode that underwent surgery had significantly higher rates of healing at 87% compared to 68% in the no surgery group. This relationship was not observed in the recurrent population. We next evaluated the center volume and center enrollment. And what we identified is that centers that enrolled more than 30 patients had significantly higher healing rates compared to those that had less than 30 patients. We next looked at our GIPS-specific population. Among our GIPS population, there were a median of 3 pits identified during the procedure with an average punch size of 4 millimeters. Most providers used between 1 and 2 different size punches. Peroxide was used in up to half of patients, with packing used in about 42%. And then very few patients received post-op antibiotics, and even fewer received a drain. The most common complications that were reported were pain, drainage, or reported recurrence by the patient themselves. In our GIPS population, the recurrence rate was reported at 9.7%, with a 15% complication rate reported in the other surgery group. Of note, the difference between these two was not statistically significant. There were no patients that required return to the operating room or re-intervention after a GIPS operation. Moving to our conclusions, the strength of this study is its large multi-institutional prospective design, as well as the combination of clinical and patient data over a 1-year period. It's limited in its non-controlled aspects, as well as limited time points for follow-up data. And additionally, the COVID-19 pandemic reduced our enrollment further. Our next steps for this group is to evaluate specific time to healing data, as well as detailed recurrence rates to further gain a better understanding of the true success and failure rate of each treatment modality. So in conclusion, a high number of patients reported healing at 1 year, independent of the treatment that they received. Among patients who present with their initial episode, they may serve to have greater benefit with surgical intervention. Next, centers with highest enrollment experience more frequent healing, and though this may serve as a surrogate for center volume, this needs to be further explored. And lastly, GIPS trephination is now frequently utilized with minimal morbidity. I'd like to thank my PI, Dr. Rymeski, as well as the APSA Foundation for the J. Grossfeld Scholar Grant, which supported this work. In addition, I'd like to thank Jennifer Knox and the Midwest Pediatric Surgical Consortium who made this project a reality. Thank you.
Questions?
Hi, thank you for that. Mary Edwards from Albany, New York. Just a quick question. Did you guys utilize phenol at all in your sort of therapeutic armamentarium? Because we've had pretty good success with it, particularly in cases where there's a long sinus or a lot of sinus tracts. The phenol really seems to help more than the GIPS. I was just curious.
Thank you for the question. I'm not sure on the exact nature because we didn't collect that data from each center, but thank you, I appreciate it.
Dr. Ehrlich?
Yeah, hi, Peter Ehrlich from Ann Arbor. A lot of patients, I know this in both medical and surgical, could have had laser hair removal. And did you control for that, or are you planning to look at the impact of a laser hair removal? Because that would be important for convincing third-party payers.
Thank you. Yes, we have the laser hair removal data for these patients. However, unfortunately, it's difficult to control because there is a higher proportion of laser hair removal done at different centers, as well as some centers that perform both laser hair removal and surgery. So they'll perform a GIPS and laser hair removal at the same time, and therefore we're working to control that in our data set. Thank you.
Tim Jansolowitz, Memphis. I think this is really important data, so thank you for presenting it. The prevalence that you cited is from data from the 90s. I think it's a lot more, pilonidal disease is a lot more common than that. It's about closer to 1%. But my question is, do you intend to kind of standardize the way that people are doing their procedure? Because I think that there was really a lot of variety, half of people using peroxide, a pretty high rate of packing the wound, which I think makes it less effective treatment. Do you know of any plans to kind of come up with a standard GIPS or a MIPE? Thanks.
Thank you for the question. I don't know of our exact plans to standardize this going forward, but we hope that this data will shed light on that and then prompt a goal for standardization once we've completed our full data analysis. Thank you.
I can answer.
Okay, go ahead, sorry.
I can answer that. We did, at the outset of the study, distribute to all of the sites information about the GIPS procedure. We made a video of what the GIPS procedure is, how it should be done, but obviously it was left to surgeon discretion how they followed that. But yes, like medical management, surgical management was laid out at the beginning of the study.
Unfortunately, we're going to have to move on, so please direct your questions to Dr. Hartman afterward.
Thank you.
Thank you.
Next presentation is by Charissa Smith. She's at the Lurie Children's Hospital as a research fellow, and she's going to talk to us about the association between palliative care and high-intensity end-of-life care in pediatric ECMO patients.
Thank you for the opportunity to present our work. We have no disclosures. Surgical procedures improve the quality of life of children with serious illnesses, but often carry significant risk. Therefore, pediatric surgeons often take on the responsibility of needing to balance the need for appropriate surgical care for critically ill children, while attempting to avoid unnecessary surgical procedures at the end of life, which could ultimately be harmful to patients and their families. Involving pediatric palliative care has the potential to decrease high-intensity end-of-life care by establishing, first, open-ended communication and coordination of care between medical teams, and helping families navigate often a difficult and time-sensitive process of complex medical conditions. However, a recent survey by Ellis and others of APSA members and palliative care physicians showed that often, while pediatric surgeons value palliative care, they were often, as a team, consulted late in the process of a patient's course of illness, and after serious clinical deterioration or death was imminent. And there was also a discrepancy among surgeons and palliative care physicians about when palliative care or how much palliative care was consulted. 43% of pediatric surgeons said that they would consult palliative care in a seriously ill child, whereas palliative care physicians reported rarely or never being consulted by pediatric surgeons. Therefore, in this study, we aimed to look if pediatric palliative care was associated with de-escalation of high-intensity care for pediatric ECMO patients, and also just to look at the patterns among this seriously ill population. The purpose of this research was to see if there was a true discrepancy between how much palliative care was consulted and if pediatric surgeons were unaware of that. So this was a multi-center cross-sectional study of children under the age of 18 who underwent ECMO cannulation and died during their hospitalization from October 1st, 2018 to December 31st, 2022. We defined high-intensity end-of-life care as having any type of invasive procedure within 48 hours of death. We performed a multi-variable logistic regression model to look at the association between pediatric palliative care and a decrease in high-intensity end-of-life care. For our results, we had a cohort of 2,377 children. Of those, 807, around 34%, had a palliative care consult, and 14% of those children had an invasive procedure within 48 hours of death. We found that children on ECMO during their terminal admission with a palliative care consult were 66% less likely to receive a high-intensity end-of-life care. Other factors that were associated with reduced odds of having high-intensity end-of-life care is the presence of a DNR order or being on VV and central VA ECMO versus peripheral VA ECMO. There are several limitations to this study. We used a secondary administrative database, so it was only accurate in terms of how accurate the billing codings were. And also, we acknowledge that pediatric palliative care is a relatively new subspecialty, which might not have been available at every single children's hospital, or the timing of the service in terms of being able to accommodate consults at all hours of the day were different. So we tried to adjust for this by looking at, in our logistic model, by trying to control for hospital level variation. And next, we were not able to know the exact timing of the palliative care consults, so that limits our ability to determine the direct cause and effect relationship of getting a palliative care consult and seeing if that resulted in decreased high-intensity end-of-life care. We can only say association. So further research with more minute details would be needed to assess the effect of early versus late palliative care referrals. In conclusion, less than half of pediatric ECMO patients had a palliative care consultation during their terminal admission. Pediatric palliative care consults were associated with reduced likelihood of having a procedural high-intensity end-of-life care. But further studies are needed to identify barriers to getting palliative care consults in ECMO patients. Possible future directions for hospitals could be implementing flags such as best practice alerts for patients undergoing ECMO, so that palliative care could be involved earlier at the time of diagnosis rather than later in care. And then also there could be more qualitative analysis to look at local barriers and facilitators to palliative care consultation, and also to incorporate patient and family perspectives. I believe this research would be important to all children's hospitals, as I think we can acknowledge the role palliative care has in helping dealing with stressful situations at the end of life for children. Thank you for your time.
Thanks. We have time for one question, and I think Dr. Arca beat everyone else to the mic.
Good morning. Marjorie Arca, Rochester, New York. It would be interesting to parse out your babies, your CDH, babies, meconium aspiration, as well as your congenital cardiac anomalies, because sometimes the expectations for those children may be a little bit different than, say, somebody with, say, multiple anomalies and they're trached and all those things. That might be a very interesting thing to do. In our institution, I'm proud to say that every single child on ECMO has a palliative care consult, which unnerved me initially, but I think it's a really good thing to do. But thank you, that was really wonderful.
Thank you, and please find her afterward for all your other questions. Next up, we have Dr. John Woodward at University of Buffalo presenting a NISQUIP pediatric analysis of patients undergoing laparoscopic appendectomy demonstrates increasing rates of same-day discharge over time with decreased admission rates. Thank you, Dr. Woodward.
Good morning, everybody. I'm John Woodward. I'm a general surgery resident at the University of Buffalo, and I'm excited to present trends and outcomes of same-day discharge for laparoscopic appendectomy. We have no disclosures. So why do we care? Same-day discharge for acute appendicitis has been shown to have high rates of caregiver satisfaction, decreased economic burden on families, and reduced overall healthcare costs. National trends are not well studied, with most of the same-day discharge research occurring at single institutions evaluating their own ERAS protocols, but those have demonstrated same-day discharge rates as high as 87%. So with national data, we wanted to evaluate our hypothesis that same-day discharge for pediatric acute non-perforated appendicitis has been increasing over time without increasing rates of readmission or other complications. We used the NSQIP Pediatric Registry from 2017 to 2021 and identified pediatric patients who underwent laparoscopic appendectomy for non-perforated acute appendicitis. We compared patients who discharged on the same calendar day of surgery to those who discharged on postoperative day 1 or day 2. We also performed a subgroup analysis on a specific diagnosis code for acute appendicitis with localized peritonitis without perforation or gangrene. We analyzed the annual data to determine the same-day discharge rate and then looked at outcome differences for the cumulative data. We identified over 67,000 patients with non-perforated acute appendicitis, and although most of the demographic and clinical characteristics were statistically different, most were not clinically meaningful, with the same-day discharge group being older, but only 9 weeks older, and their operations taking less time, but only 4 minutes. When looking at the annual trends, we note an increase in same-day discharge rate over time, with the rate being 33% in 2017 and increasing to 53% in 2021. Also on this figure is a prior NSQIP P analysis that identified a same-day discharge rate for non-perforated acute appendicitis of 22% in 2015. When we looked at the outcomes, we found that there were equivalent or improved outcomes for the same-day discharge cohort. We found unplanned readmissions occurred at a lower rate in the same-day discharge cohort at 1.3% compared to 2.1%, and unplanned reoperations were equivalent at 0.3 and 0.4%. When we ran our subgroup analysis, we identified over 7,000 patients, overall with fewer significant demographic and clinical characteristic differences, and an annual rate that similarly increased from 50% in 2019 to 60% in 2021, also with equivalent or improved outcomes for the same-day discharge patients. Our analysis is not without limitations. NSQIP P was utilized for this and is retrospective with data limited to 30 days. Also, there is concern about miscoding of complicated and uncomplicated appendicitis using ICD-10 codes, which is why we excluded patients who stayed longer than 2 days and why we ran our subgroup analysis. In conclusion, same-day discharge rates for non-perforated acute appendicitis have increased annually to over 50% in 2021 with improved or equivalent impact on complications. These trends underscore a shift in postoperative management aligning with a growing body of evidence advocating for same-day discharge and uncomplicated appendectomies, and likely a larger percentage of patients could be candidates for same-day discharge nationally. We'd like to acknowledge the American College of Surgeons and provide the following disclaimer on their behalf. Here are our references, and I'm happy to take any questions. Thank you.
I have a question. Oh, go ahead. I have a question.
Yes.
Why do you think more people aren't discharging same day?
I think a lot of it, at least in the literature and personal experience, has to do with both expectation setting with patients. So letting them know that they will be going home same day or that that is the expectation, as long as everything goes okay. As well as sometimes patients don't have good support networks, aren't able to make it home the same day of surgery. But with good support services, that could be overcome.
Hi, Tony Escobar from Mary Bridge in Tacoma, Washington. So one of the things that we're seeing is, and I've commented on this in prior meetings, is a decrease in interest of general surgeons to operate on kids locally. So we're becoming a referral center for APPEs. And these patients come from pretty far away to get their appendix out, and at midnight or 1 o'clock in the morning, it's not quite as convincing to say you can go home now. So I think that in terms of saying resources or that sort of thing, there's a big difference depending on the time of day. It's amazing how it always is after 5 p.m. So how do we take this data that is pushing for same-day discharge and reconcile that with families that are traveling a fair distance just to have their appendix out.
Yeah, and I think not every patient is a perfect candidate for same-day discharge. And if they do have that long travel time, they may not be the exact right person for it. But if they were to undergo surgery at 1 a.m. and then discharge at noon that same day, that would still be considered, at least from this data, same-day discharge. And if you wait until the following morning, do the surgery, and then they go home the same day, that would be considered same day.
Hi, Doug Miniotti in California. Technical question, are you defining same-day discharge, I thought I heard you say, as the same calendar day?
Correct.
And was that, why did you pick that definition as opposed to less than 24 hours?
Limitation of the NSQIP pediatric database. They will record the date of surgery and the date of discharge, which is how they calculate the length of stay post-operatively.
Got it. And so that may also affect your data to trend lower. I would also just comment that we also have patients that come from far away, and expectation setting, I think, is the important thing. And so we talk to them pre-op about it, and you'll be surprised at how many families would be happy to drive an hour and a half, 2 hours to get home and sleep in their own bed that night, whether it's 2 a.m. or 3 a.m. It's important just to give them the option.
I'll second that. Doug and I overlap areas. Thank you very much. Okay, thanks, Kat.
Thank you so much.
Our next topic is presented by Dr. Roberts, who's a resident at Cone Children's, and he talks about something we hear about here, unfortunately, way too often, but she presents on state laws protecting child access to firearms are associated with decreased firearm mortality.
Good morning. My name is Bailey Roberts. Thank you for the opportunity to present. We have no relevant disclosures. So firearms have been the leading cause of death for children in the United States since 2019. And despite this huge mortality problem that we have, there's still little evidence about what is actually helpful in preventing these mortalities. We do know that states with stricter gun laws have less gun-related deaths, and that these stricter state gun laws are also associated with decreased pediatric gun-related deaths. As shown in this graph, you can see a decreasing trend with increasing gun law strength. So we did this research to better understand the factors that can affect pediatric firearm mortality, and this is important because it can inform future advocacy and political initiatives for the most effective ways for prevention. Gun laws have lots of different topics and can cover a lot of different things. Consumer and Child Access Protection, or CAP laws, are intended to protect people from firearms who shouldn't be accessing them. CAP laws are regulated by states and therefore have lots of different varieties. Even amongst states that have CAP laws, there's differences in the strengths of CAP laws, as shown in this map of the United States, where the strongest CAP laws impose criminal liability on gun owners that have negligent storage of their guns, whereas weaker ones just have gun owners not able to allow children to access their guns. So given this, the aim of this project was to correlate the strength of consumer and child access prevention laws with pediatric firearm-related deaths. To do this, we utilized Giffords and CDC Wonder databases. Giffords Law Center is an organization that assigns points for strength of firearm laws by category. Using Giffords allows us to assess a more granular assessment of the laws, which can assess for more of the variability amongst the states. In particular, Giffords Law Center assigns points for CAP laws that include negligence of gun owner storage, storage of guns in an unlocked and loaded way, and also points for age restrictions for buying guns. CDC Wonder is a database that reports on firearm mortalities, and we used the firearm-related death rate per 100,000 children for this study. In this study, we included children aged 0 to 21. We correlated the Gifford State CAP law strength, which is a score out of 10, to firearm-related death rate in 2021, and performed some analyses by stratifying by intent. First, we found that the firearm death rate significantly decreases with increasing cap law strength. As you can see in the orange line here, there is a decreased correlation with an R-squared value of 0.38, which is a significant association. To further drill down on where these cap laws might be preventing deaths, we looked at the firearm deaths by intent. We see the firearm homicide rate also had a decreased negative association with the cap law strength, and that states with more strong cap laws had much lower death rates by firearm homicide, with an R-squared value of 0.22, which was also found to be a significant association. Similarly, when looking at the firearm suicide rate, we find a negative correlation with an R-squared value of 0.27, which is also now noted to be significant. So overall, we find that states with stronger cap laws have decreased rates of firearm homicide and suicide, which these cap laws may be contributing to protecting from children have firearm homicides and suicides. So in conclusion, states with stronger laws protecting children from firearms have a lower firearm-related death rates. These laws are shown to protect from both suicide and homicide-related deaths. But understanding which laws amongst these cap laws and other laws have the greatest effect on firearm mortality protection is necessary, and we need more granularity of deaths and non-fatal firearm injuries in order to necessitate the political advocacy needed for the most effective means of prevention. Thank you, and I'll take any questions.
Back microphone, middle.
Thank you for a great presentation. Bindi Naik from Houston. I have two questions. First of all, why did you choose 0 to 21 as your age cutoff? And secondly, how can you be sure that those effects are due to the cap laws? Because those states that have strong cap laws probably also have strong laws for background checks and other means of access. I can tell you I'm from a state with a strong cap law in Texas, and it's not enforced at all. So I'm not sure that the cap law actually has, to do with those numbers in our state, but I can't tell you about the other states. What do you think?
So to answer your first question, we chose 0 to 21 just based on the age restrictions that Giffords assigns points for. There are age restrictions for buying guns, and they chose 21. But we have performed similar analyses looking at children 0 to 19 or 0 to 18 and see very similar trends. And to answer your second question, you're absolutely right. These are just correlations between the cap law strength and mortalities, and there's a lot more granularity that needs to be assessed there. We're working on looking at all the different categories of laws and seeing which categories correspond most strongly to this decrease. But right now, we don't have any data to assess for enforcement of those laws or any crossing of state lines. So we're kind of just working with what we got right now.
Okay, thank you. Really important work. Thank you so much.
Thank you.
Dr. Brandt?
Mary Brandt from Houston. Thank you so much for this really important work. And I kind of have two thoughts. One is that this data is so critically important, but it's also not going to be the thing that's going to change laws at this point. It's probably more like stories and just the political climate we're in. So I don't know what other parts of advocacy you're doing in addition to this necessary but not sufficient. The other question I have has to do with really profound variability, particularly on the left side of your graph. And there's two states that looked like they were super outliers with very high rates of death, even though they were on the left side of the curve, they stood out. And I wondered if you looked at any specific states along the line of Bendy's question were there other identifying factors you could see or hypothesize might be playing a role in that variability?
Yeah, so we're working on drilling down into the more granular aspect of that. I do think, like was mentioned earlier, some of those states can be something like Texas where they're not as enforced, but there are a lot of guns. We're also working on looking at a county level and assessing by the demographics to see if we can control for other factors that affect firearm violence. And that might also have an effect on the laws.
This is going to be a very quick question. May not be able to answer that. Did you look at the overall mortality rates as well, including non-gun violated, gun-related homicides and suicide? Because I mean, what you really want to see is an overall decrease in mortality, right?
Absolutely. We have not correlated the gun law strength with overall mortality, but that's a really good point, as it might just not be firearm-related deaths. We might be able to prevent other types of deaths, or we might be focusing on the wrong area.
Thank you.
Thank you.
Next up, we have Dr. Mohammed Al-Hadi from the University of Tripoli presenting mortality following complications after surgery for children in Africa, a 14-day multi-center prospective observational cohort study. Dr. Al-Hadi.
Thank you very much for this great opportunity. I'm Mohammed Al-Hadi. I'm a resident and also an incoming research fellow at Houston Methodist. It's a great pleasure to be here with you and present this study after a very long journey that took me about 5 flights. So today I'm going to present the mortality following complication after surgery for pediatric children in Africa, which is an SSP study. I have nothing to disclose. So why we conducted this analysis or this research? Our motivation for conducting this research work was to identify the post-operative complications that need targeted interventions to decrease failure to risk and improve patient safety. This is crucial because we are presenting research because to highlight a public health crisis. The study reveals severe health care inequalities and alarming surgical outcomes for children in Africa, demanding an immediate action from the global healthcare community. So what's our study? SSPEED was a 14-day prospective observational study that involving about 8,600 patients under the age of 18 across about 248 hospitals in about 31 African countries. It spanned from January 2022 up to December 2022. So what was the main finding in our study? The finding was alarming. As we can see here that we have 18% of children experiencing post-operative complications. The mortality rate overall was 2.3%, which is almost 12 times higher than high-income countries, according to a meta-analysis that we have done. Also, as we can see that notably here, that about 11.6% of these deaths has been on the day of surgery. And also, we can see that there was a high rate of mortality following complication, and also that highlighted with 10.8%. So we are here to determine which complication that has occurred after this surgery, and also we're focusing which the independent risk factor that has been associated with this mortality. So understanding this will help us to guide which intervention that we need to aim to reduce this failure to risk. As you can see that we have about 249 hospitals in 31 countries covering a large area of African continents. We will be focusing on those has developed complications, which are about 1,530 patients, and 166 has died, unfortunately. So in the patient characteristic here, we can see that clearly that our analysis here that showed that these patients, that younger age groups, especially neonates and infants, had higher rate of mortality rates, also those with higher ASA, and indicating that preoperative health has more related risk factor for mortality, and also emphasizing the care for more vulnerable in these groups. For the complication, infection was the most common complications here, with higher occurrence of deep infections, body cavity infection, and pneumonia, particularly emergency surgery, which has higher mortality rate. Cardiovascular complications, though it's less common, but has been very severe, and also bleeding and acute kidney injury, pointing to the complex of high-risk surgery in these pediatric age group in these countries. So the main thing that we need to focus on, which we have done through the generalized linear regression model, is what are the factors that independently associated with mortality following complications in Africa. We have revealed several risk key factors. These are the age groups, especially younger age group, higher ASA category, emergency surgery, barren surgery compared to other surgeries, longer surgical duration, superficial site infection, and cardiac arrhythmia, and also acute kidney injury. These findings, of course, highlight the need for enhanced preoperative care for high-risk groups. As you can see, so the conclusion is our comprehensive analysis indicated that younger age groups, higher ASA, which indicate that preoperative health poor outcomes, and emergency surgery has significantly increased the risk of mortality following complication. Additionally, some complication like superficial site infection and arrhythmia can increase the risk of death. So what we need to do is to address these complications to reduce the failure of risk, because this can help us to reduce this mortality in patients in Africa. And also we call for some the healthcare leaders around the world, the policymakers and funders, to address these disparities and ensure safer health surgical care for these patients in Africa to reduce this risk of failure. Thank you very much for attending my presentation, and also I would like to thank all the collaborators around Africa who has participated in our study.
Hi, Peter Ehrlich from Ann Arbor. First of all, I just want to congratulate you for getting data from 31 countries. That's an unbelievable effort. And you mentioned that you want to address this. What do you think it would be the first and most important factor in addressing your outcomes?
Thank you for these good questions. I think we have, let's say that we have three categories that we need to focus on. There's a human resource category, which means improving the training for surgeons in Africa, because this was one of the main issues that we find, although due to the time of the presentation, I can't show you more data. But we have low level of training in Africa, specifically in pediatric surgery, and we have high number of patients toward the surgeon. The second thing that we need to focus on preoperative care. Unfortunately, as we can see, that infection is very prevalent, and also these patients are coming very poor. They become with high RSA, they become late stage surgery because they have what we can say that weak access to surgery, or let's say poor access to surgery in their countries. So we have some variables, although the presentations can be lengthy, that we found that these patients can take some months or weeks to be able to reach a hospital and get surgery, which of course can show that these poor outcomes.
Yes, hello, Frank Margorone from Children's Hospital, King's Daughters. Two questions for you. One, does this data include data from in-country surgeons as well as visiting surgeons from other, more advanced countries as far as healthcare systems? And number two, does this include kind of regional hospitals or just the hospitals within the network? Because obviously, care in Africa as far as regional hospitals may not be even to the standard that you're describing.
Yeah, we have included 3 or 4 types of hospitals. The tertiary hospitals, which were the majority of hospitals participating in this study, and secondary care hospital, as well as charitable, or what you have mentioned, like those hospitals that has been done like field hospital, for example, in Africa during some times during the study. So it includes a wide variety of hospitals, from tertiary care up to charitable or any other type of hospital. Yeah.
Did you stratify outcomes based on those missions groups versus those done in country by the expert?
Yeah. In the regression model, we haven't included this as one of the variables, but due to the low number of these hospitals, because it's about, I think, 10% or something, we haven't included them. We just described them. I have this slide, if you wish. I can show you the specific numbers and specific frequency of these hospitals. Yeah, thank you.
Thank you very much. This is our last presentation of this opening session. Dave Ebert is a student at Nemours Children's Health Delaware, and he's going to present late onset aortodigestive morbidities after tracheoesophageal fistula repair.
And this is via video.
Thank you so much for the opportunity to present today. We have no disclosures. EATF, esophageal atresia with or without tracheoesophageal fistula, is a relatively rare condition thought to occur in about 1 in every 4,000 live births. Historically, this had a low survival rate. However, Over several decades, multimodal care with advancements in surgical approaches and neonatal care has improved survival. This has also led to the challenge of managing potential morbidities in the long term, especially as people with this condition now survive into adolescence and adulthood. So basically, we're really good at taking care of people at the time that they're born with this condition, and now we're interested in the long-term outcomes. To study this, we did a retrospective analysis using a multi-institutional database called TriMedics that follows electronic health records in over 80 institutions internationally with over 100 million patient records, and it follows the EHR data for each patient for up to 20 years. To define our cohorts, we used queries with ICD-9 codes and ICD-10 codes, and we queried for those with congenital EATEF, and for our control group, we queried for those with no congenital disease, a pediatric encounter, so that they entered the database, and we chose 30 years old as a cutoff to allow for data processing constraints and to allow for a relatively normal distribution within our cohort of interest. We also did a subgroup analysis within the EATEF population of those who had concurrent congenital heart disease. For the morbidities, we looked at esophageal and respiratory morbidities. We used ICD-9 and 10 codes as well as CPT codes. And esophageal morbidities have been well studied in the literature, but we also wanted to look at respiratory morbidities, especially in the long term. We propensity scored matched to allow for an even distribution among our groups. And now looking at the results. After propensity score matching, we had about 2,600 patients in each group. We also had evenly matched demographics. And then we also wanted to point out that while TriMedics follows the patient records for up to 20 years, the current median age within each group was 13 years old. Now looking at the morbidities. On the chart here, this includes any time a patient had a diagnosis entered into their electronic medical record for up to that 20-year period. And so for esophageal morbidities, which has been well described in the literature, we see it re-demonstrated here that there's a significant difference with the EATEF group for GERD, dyskinesis, stricture, and the need for a dilation procedure. Now moving on to respiratory morbidities. Here we see a significant difference in the rates of respiratory morbidities across all conditions studied, and this includes asthma, pneumonia, and obstructive sleep apnea. Now going on to our subgroup, and here we can see that congenital heart disease is an independent risk factor within the EATEF population. And here we can see a significant difference in GERD, dyskinesis, and the need for a dilation procedure. Looking at respiratory morbidities within our subgroup analysis, again, we see that congenital heart disease is an independent risk factor within this population. And this includes, again, asthma, pneumonia, and obstructive sleep apnea. So per our intention to look at these conditions over the long term, we did Kaplan-Meier morbidity curves that follow the patients from the time they enter the database for potentially up to 20 years. And here we can see that the gap between the curves continues to widen over this 20-year period, suggesting long-term or late onset effects. And we see the same thing with respiratory morbidities, that the gap continues to widen over this 20-year period. Concluding, we see that EATEF has a higher overall esophageal and respiratory morbidities, both in the short term and long term for this group of patients. We also see that congenital heart disease was an independent risk factor for both the esophageal and respiratory morbidities. Tying it all together, we see the importance of counseling, long-term follow-up, and long-term multidisciplinary care. Thank you so much. I appreciate your time.
Unfortunately, I don't think we can ask him any questions. You can? Good. Perfect.
We have a representative.
Benson Ahod, Boston. Thanks for bringing this to our attention and for raising awareness. A couple questions. First, I think we have to stop perpetuating the misdiagnosis, misclassification of these kids as asthmatic. They rarely are asthmatic. In fact, many ever get PFTs that show that they have asthma, so it's malacia. So I wonder if your diagnostic codes looked at trichomalacia. That's one. The other one is related to what do we do about this, right? I don't think we should rest on our laurels and say that, oh, we're doing a great job early on, because I think there's still things we can do early on in that initial repair to prevent all of this from happening. For example, we've shown that posterior tracheopexy at the time of initial repair significantly improves the respiratory morbidity in the first year of life. We've also shown that protecting the vocal cords decreases aspiration, pneumonia with intraoperative nerve monitoring. So there's a lot of things we can do up front. So what are your thoughts on that?
Absolutely. Thank you, Ben. Just to clarify, I'm Matt Bullock. I'm from Nemours in Wilmington. Dave couldn't be here, so he did the recording, and we're just grateful for his work on this project. So just to start with your second question, totally agree. I mean, I don't really have much else to say about that. I agree that there's obviously more that can be done. The asthma question is a good one. We did not look at tracheomalacia. We could go back with the Trinetics team and do that. That's a good point. That's something we could look into doing. But I think that's a very valuable point. Thank you.
We can take one more question from the internet this time, Dr. Ochoa.
Hey.
From the chat, were there any esophageal cancers in this cohort?
There were not. We actually were looking to report on that, but there were not any reported. Thank you for that question.
I think that concludes the session. Please stay in the room. Dr. Powell's going to come back up and introduce our exciting keynote speaker.